medial and hind foot pain, medial ankle and hind foot pain.
Thank you, everybody, and thank you for attending this session and not attending the swimming pool session. Anyway, so I'm going to present in the next 15 minutes about some causes of the medial ankle pain, whether it's acute or chronic. I always like to start this presentation by talking about the anatomy, and just to let you know that half of my talk will be anatomy, because the anatomy of this side of the ankle, the medial ankle, is a bit complex, and understanding of the anatomy is very important. The most common entities or anatomy you come across in the medial side of the ankle and hind foot is the ligaments and tendon, and the main ligaments are the medial collateral ligaments, what we used to call deltoid ligaments, and the calcaneonavicular ligament, what we used to call spring ligament. So we don't like to use this term deltoid and spring ligament anymore, but just to let you know. From the tendons, there is the posterior tibial tendon, there is the flexor digitorum longus, and the flexor hallucis longus. And the most important tendon on the medial side is the posterior tibial. So we'll start with the anatomy of the medial collateral ligaments. As you can see, it's a complex ligament, and that's why sometimes they call it medial collateral ligament complex, because it's complex, and it's divided in superficial and deep. The superficial is if you start from anterior to posterior, is the tibionavicular, tibiospring ligament, the tibiocalcaneal ligament, and the superficial posterior talolebar ligament. And the deep is easy because it's only the anterior and posterior talar ligament. As you can see, it's complex, but if you want to just to remember one ligament, which is the most important ligament in the medial side, I would suggest that you remember the tibiospring ligament, so if it's too much for you. And how we can see this in MRI, mainly better is in the coronal images. And if you go from anterior posterior, you'll start by seeing this thick, nice ligament, which is the tibiospring ligament. And the reason why it's called tibiospring ligament, because you can see it has a direct attachment into spring ligament. So it doesn't have an attachment into the bone, but actually it attached into the spring ligament. If you move slightly posteriorly, we see the posterior, the tibio-talar ligament, and if you move further posteriorly, we're going to see the deep tibio-talar ligament. We're going to see the tibiocalcaneal ligament, and you can see the flexor retinaculum. And as you can see, between the MCL of the medial side ligament of the ankle and the flexor retinaculum, you can always see the posterior tibial tendon. So this MCL can be seen in MRI, and also if you are good and you expert in, or you do ultrasound a lot in your institution, can also be identified. You can carefully, if you spend some time, you can see all this ligament, but again, the important one is the tibiospring ligament that you can see on the side, and you can see it has extension into the spring ligament. So ultrasound is very useful also to identify the anatomy. The next important ligament that we come across in the medial side is what we used to call spring ligament, which is called the calcaneonavicular ligament. And as you can see, its component is three components: the superior medial, and the medial plantar, and the inferior plantar. Again, if you just want to remember one ligament of this complex, I suggest that please, the superior medial is the most important component of the calcaneonavicular ligament. So how this can arrange, why these two ligaments and spring ligaments are important, because it is responsible for protecting and maintaining the arch of the foot by covering the medial side of the ankle and midfoot like that. And this is further supported by the medial collateral ligament and also the posterior tibial ligament. So all these three components are there to maintain the arch of the foot, especially during walking. So if you want to see and analyze or assess the spring ligament on the coronal MRI, I think you're going to see it attached to the tibial spring ligament. So this is the superior medial component on the coronal. And if you go further down, you see the medial plantar and the infraplandial. So all of them, you can see, is continuously and as if they are holding the arch of the foot and protecting the arch of the foot. Similarly, you can see this in the axial view, when you can see always the relation of the posterior tibial and the inframedial, superior medial aspect component of the spring ligament, as you can see. And you can see that the structure, this thick black structure that always seen between the talus, the head of talus, and the posterior tibial ligament, this structure is the superior medial calcaneonavicular ligament. So the other anatomy is the tendon anatomy that you need to know, and the posterior tibial tendon is one of the main flexors of the foot. And again, everything is not straightforward in the medial side of the ankle, because the anatomy or the insertion of the posterior tibial tendon is more complex than you think. But the thing is, because of its name, the posterior tibial tendon is always seen posterior to the tibia and covered by the flexor retinaculum. The thing that you need to know that the only tenosynovium covers the area behind the medial malleus and the distal tibia, but the distal 1 centimeter of the posterior tibial tendon doesn't have a tenosynovium. Why this is important? Because it's very unlikely that the distal 1 centimeter will have tenosynovitis. It's more likely to have tendinopathy because it lacks a tenosynovial sheath. So this can be seen in the coronal view and what we call the tarsal tunnel, as the tendon goes into the ankle, and the ankle is always seen between the flexor retinaculum and the medial collateral ligaments as you go posteriorly to anteriorly. If you go further down and anteriorly, you're going to see this interesting and characteristic relation between the posterior tibial and the superior medial component of the spring ligament. And sometimes we see this synovial layer between them. So that's why it's not a surprise in someone who, like a marathon runner or someone who likes to run for long distances, that we see some fluid here in this area. And this sometimes is difficult for us to identify whether this is just physiological or because of inflammation in this area. Ultrasound is good in also in scanning and identifying the relation between the posterior tibial tendon and superior medial calcaneonavicular ligament by carefully scanning the posterior tibial tendon and going further down inferiorly at this level, and where you can see nicely the superior medial calcaneonavicular ligament and the posterior tibial tendon on top of it. Just to, as I mentioned, the insertion of the posterior tibial tendon is a bit complex. It has different components, the anterior component and the middle component and the posterior component. The anterior component is the well known to us, and we always been asked in the medical school where is the insertion of the posterior tibial. We always say it is navicular tubercle, but it also have some fibers that goes to the medial cuneiform, and if you further down goes to the bases of the cuneiform, cuboid, and second and third metatarsal, and have a posterior recurrent fibers that goes posteriorly. So you need to know that, because sometimes you identify the anatomy. But again, if you want to remember one thing of this slide, just is the anterior component, because this is the component that always get inflamed. So how we can see it? We can see it in the sagittal plane, and we can see the tendon moving down, have the main insertion into the navicular bone, but sometimes you see this external sliding that goes to the cuboid. And you can easily see also in ultrasound. And if you are interested to show the other insertion of the posterior tibial ligament, all you need is to follow the tendon further down the axial view, and you can see the different slings that goes and insert in the bases of the metatarsal and the cuneiform bone. So we'll move now to the second part of the presentation is the pathology. And the most commonly inflamed tendon in the ankle after the Achilles tendon is the posterior tibial tendon, and it's mainly for overuse, degenerative change. It could be part of the inflammatory process. It could be secondary to osteotrigonum, or of course, indeed, secondary to trauma. The spectrum ranges from tenosynovitis, tendinopathy, and partial tear up to complete tear. So one of the predisposing factors that affect leads to tendinopathy is the presence of osteonaviculae, and the osteonaviculae have as you can see, three types: type 1, type 2, and type 3. And the most common one that can be associated with posterior tibial is type 2. Also type 3 can have. So a high percentage of patients who has posterior tendinopathy have osteoacromiorrhea, but not the other way around. So by itself, osteonaviculae does not indicate posterior tendinopathy. So what we can see on MRI as any tenosynovitis in our body, you see thickening of the tenosynovial fluid and thickening of the tendon itself. So there is no specific characteristic of tendinopathy of the posterior tibial tendon in this area. And same thing in ultrasound, you see thickening and fluid around the tendon. So it's a typical appearance of tenosynovitis. For tendinopathy, especially associated with accessory navicular bone, same thing. You can see thickening and altered signal of the posterior tibial tendon. And if you do ultrasound, you can see increased Doppler, and you can see in this patient have also accessory navicular bone. Partial tear can happen. So if the tendinopathy is chronic and is not treated, though they can lead into a partial tear. And you can see this patient that there is this tiny fibers which is intact in axial view, and on the sagittal view you can see that it's partial tear with fluid around it, and similar thing can appear in the ultrasound. Complete traumatic tear for the posterior tendon can occur, and it is a straightforward diagnosis on MRI. All you don't see is there is tendon completely disappear. Especially if you check the tendon in the tarsal tunnel, you can see in this patient there is no tendon fibers whatsoever, indicating a complete tear of the tendon. I find it difficult to identify this complete tear or have good pictures with ultrasound, because most of the time the tendon gets pulled proximally and you cannot really identify. But this is the nicest image I managed to get with the panoramic view. But you can see that the tendon is pulled here, and there is a big gap of no tendon not identified. So just a quick understanding of the relation of the posterior tibial tendon with the calcaneofibular ligament. The posterior tibial tendon is the one who flexes our ankle during walking, and also its support need to be supported by the spring ligament or calcaneonavicular ligament, especially at this stage when there is lift up. So what the spring ligament or the calcaneonavicular ligament do is lock the midfoot and prevent it from going into inversion. That's why they work in tandem by flexion and locking the midfoot. So what will happen when you lose your posterior tibial tendon? That's exactly what happened. Whenever the patient tries to flex his forefoot, this causes more pressure on the hind foot and cause more pressure on the spring ligament and leads tearing of the spring ligament, because the spring ligament this is where it is located. So that's what happened in chronic cases. You see posterior tibial tendinopathy, and you can see that navicular, the superior medial calcaneonavicular ligament is also affected. So, and if used chronically, it can lead to complete tear of the ligament. That's why there is close relation between the tendon and ligament. So, like any other problem with tendon, it can dislocate. And this is an example of another patient with anterior dislocation of his posterior tibial tendon. Another example of complete tear of the calcaneonavicular ligament, and in this patient you can see that the tendon is completely sitting on top of the talus, and when you see this relation, that means there is a complete tear. So just a final thing about what will happen if you ignore those patients. You can see it starts by having posterior tibial dysfunction. This can lead to tear of the spring ligament or the calcaneonavicular ligament. This causes further instability, can affect the MCL, and then can cause problem in other sides. So it might start as a simple inflammation of the posterior tibial tendon, but if it's not treated and ignored, can cause lots of problem of the whole ankle and cause impingement and even affection of the other side. A quick 2 slides about the medial collateral ligaments. We already went through in details about its anatomy. The thing is, when there is acute tear of the medial collateral ligament, it happens during supination with dorsiflexion, and always start by the deep component and goes its way out. So always the medial component, then the lateral component. And the MCL is like the ACL of the knee. So it's very unlikely to be isolated. It always, when you see an MCL ligament tear, always look for other ankle problem, like osteochondral injury in this patient, and also this patient had a lateral collateral ligament injury. So it is very important to look for other injuries. One last point, whenever you see this tiny avulsion fracture of the lateral malleolus, this is an indication of avulsion of the flexor retinaculum. And as I mentioned, always the ligament tear happen from medial to lateral. So when you see this avulsion fracture of plain X-ray or CT, that means that the MCL is torn. That means there is probably another associated injury with the MCL. Okay, so I will stop here, and I just want to show you, invite you for the next ISS meeting, which will be in London, okay, in October. So if you are interested in musculoskeletal imaging, please come to London and attend the International Skeletal Society meeting. Thank you very much.
Thank you, Dr. Ramy, for the nice presentation. I'm so sorry, I think there will be no time for questions at the moment, so maybe at the end, if there is any question, if we have time. Thank you so much.